off what you do and what you're going to talk about.
Good morning. So, I'm Jessica Lavelle. I am the Women's Treatment Coordinator at Ohio Moss. So, I'm going to talk in my presentation today about my job and what I do. I'm a licensed social worker. I've been in this position for about a year now, but prior to this, I've worked with primarily women. The bulk of my work was in women's prison in the mental health department there. So a lot of experience with this population, and I've also worked with families and in hospitals and some other things. But I'm excited to use that experience to try to grow women's services around Ohio. So that is me. Is my I don't know if my screen is, do I need to redo my screen?
Yeah, you'll have to redo it. Sorry.
Okay. Is that showing up okay?
Yes, it is.
Perfect.
Okay. So yeah, that's me. So I brought a lot of different information today. It sounds like there's a lot of experience in this space, so I can go quickly through a lot of it. Um, but to kind of talk about what I do, so every state has a women's service network coordinator or me, and our main function is to oversee a federal set aside for women's SUD treatment. It's a part of the Substance Use Treatment and Prevention Block Grant. And so Congress sets this money aside because they recognize women with dependent children and pregnant women as a priority population. If you have a woman, you have to treat her family because that's how they're going to be successful. So part of this grant is the requirement that you're providing gender specific treatment, case management, you're making sure women have integrated care, access to childcare, other therapeutic interventions, transportation, and again, must treat their family as a unit. So what I do is I assist these agencies by providing some TA for grant specific things, but also we share resources, training opportunities. We put together women's treatment and FASD symposium in the fall to provide networking and education opportunities, and just really trying to advocate and understand the needs of women in Ohio and their families. So this is for fiscal year 24, which ended in July. Well, federally, it ended in September. But you can see this is around the state, the different locations of the agencies that receive this funding. And so for last fiscal year, we had over 1,100 patients served. 31 of these programs are residential programs, and 23 are outpatient based, including a couple that do specifically care coordination or just recovery supports for pregnant and parenting women. I just finished yesterday. I went to every single one of these sites in the year and got to learn a lot about what they're doing. And they're doing some amazing work. But I've kind of, through reporting and site visits, learned, typical modalities or interventions they're using. So individually, they're using a lot of motivational interviewing, a lot of trauma-informed care, which naturally fits this population, some DBT, and we see a lot of the group programming going on as seeking safety, a lot of matrix model use, and a lot of like Stephanie Covington's materials being used. So that's kind of what's going on with this specific grant around this state. And so part of this grant's requirements too are that agencies have to prioritize admission for pregnant women with active substance use and those that are using IV drugs. So again, this I can kind of skim through. It sounds like we have a lot of great experience here, but things that we look for to try to inform the care in these programs are understanding specific needs of women with substance use disorder. So we look at, differences in initiation of use that usually begins at an older age than it does for men. I think highlighting that importance of how relationships impact women are important. I know from my experience working with women, very relationally focused, even if it's not always a healthy or positive thing, just keeping that in mind when you're treating women. But a lot of times they get introduced to the substance by a partner, a spouse, a boyfriend, even in my experience, parents at a young age are introducing it to girls. Obviously, familial substance abuse has an impact on everyone, but for girls and women specifically, just this kind of trend I would always hear is this: growing up fast, I had to take care of my siblings, I had to take care of the household, I had to take care of my parents, and so all of that can lead to substance use. This is a very general discussion on women, but sexual orientation, they have found that there's some higher rates in minority groups, lesbian, bisexual, etc. But that's likely just compounding gender identity and maybe other identities. And then personality measures, obviously sensation seeking, having high anxiety, self-worth and self-perception are big with women. So we have a lot of agencies working on self-esteem, just general kind of overall giving them skills and things to feel proud of. And then again, it can be compacted by other factors such as, racism, having low SES, and ethnic minority. All of those various identities can be compounded to be risk factors as well. So trauma history, we talk a lot about trauma-informed care in these agencies because of the high percentage of women who have experienced trauma that have a substance use disorder. So we're really talking a lot about what kind of trauma-informed care. A lot of agencies are also working on, just as an agency, in everything they do, from interacting with the front desk person to maybe the residential aides. Everyone is being trained on trauma-informed care, which is great. And then women are more likely than men to experience co-occurring mental health and SUD diagnoses. So we're seeing a lot more, which I'm happy. I don't know why I ever separated, but a lot more combining of mental health and SUD treatment instead of separating it. A big push for our agency right now is integrated care, which I think is needed. So we look a lot at pregnant women. So this grant specifically looks at pregnant and parenting women. And a big piece of that is obviously the postpartum or perinatal depression and the high instances of that in this population. Many go undiagnosed, many don't seek treatment. If you look at women that are in poverty or rural areas, they're at heightened risk for postpartum depression. We also see, women of color increased risk again because of those compounding factors of extra discrimination. Our systems aren't always set up in a culturally aware way. And so they might face issues such as lack of access, organizational or sociocultural barriers. And if you look at Black women specifically, 60% of them with postpartum depression don't receive treatment because of those things. So these are all, I'm just sharing these because these are things we're taking into consideration when we're doing this work in the state. Specific concerns. So this is something that's been, a hot topic in our field, the perinatal substance use. We've seen that there's been a really big increase in SUD and accidental overdose among perinatal persons. So specifically women 35 to 44, their numbers tripled over the years of 2018 to 2021. We also found that 20% of women with the perinatal depression have a history of substance use, and then 22% of those with perinatal depression had illegal drug use during pregnancy. And again, these are things that we're trying to work on. So many women don't disclose their substance use issues because of stigma. fear of penalization. So children's services, having their baby taken away, which is, another very traumatic thing. So we're really working with agencies on how we can better advertise services to pregnant women and let them know that they can receive treatment and they should receive treatment. And it's, just like receiving your diabetes treatment during pregnancy, there's, shouldn't be a stigma to that. So Ohio specifically, the PAMR, which some of you may be familiar with, we've found that mental health conditions, which include substance use disorder, were the leading cause of perinatal deaths in our most recent PAMR report that's come out. 32 of those 36 mental health related deaths were from overdose, and 91% of those were found to be preventable. So a big piece of that we're looking at in my department and other state agencies is this lack of care coordination. So women not getting to the treatment or not getting follow through on the treatment that they need. Again, maybe not knowing what services are out there or being in an area that has, lower access or issues with transportation. So some other contributing factors are a lack of knowledge and support persons. I think that stigma kind of carries through for everyone, or just not understanding that care is there. Lack of access to resources and limited access. So maybe living in an area where there's just lower numbers of providers in general. And then we look at the impacts of the children of these women. So the grant that I have talks about, again, serving the family as a unit and making sure the requirements state that we have to make sure that these women's children are getting access to the care they need. So, I'm sure you're all familiar with the reasons why, but, there's increased risk of behavioral issues, developmental issues, attachment cannot develop as well. Sometimes if a mom is not treated for her behavioral health needs, we see some concerning numbers with NAS or NOWS. Between 2016 and 2020, Ohio had over 9,000 babies born with NAS and NOWS. And then children with parents with an SUD are more likely to be of lower SES, have higher rates of mental health and behavioral health disorders, and more likely to develop SUD themselves. So these are all things that we're considering when we're trying to put resources out in the field and where to focus our efforts. There's a lot being done with safe plans of care right now, which we're hoping to expand, and I can talk a little bit more about that later. So again, these are kind of things that we look to inform the services and programmings that we're providing. So treating the unique needs of women. Again, recognizing that there can be gender differences or sex differences. I'm sure you're all aware that most of our research in the beginning was done on men. And so we need to focus on, how these different interventions impact women and how we can be gender sensitive in our care. So the relational approaches, that has been one of my big takeaways from working with women, is just that importance of relationships. They're gonna, want to feel connection, want to feel accepted or loved by, people. Not that men don't want that, but it's just kind of a different way of interacting for women. Especially, I worked in the prison. They kind of create their own family units in there, get into some relationships in there, and, just really focusing on what does it look like to have healthy boundaries, healthy relationships. A lot of women ended up in prison because of a bad relationship. So that's one of my big takeaways from working with women for so long, is just that importance of having healthy relationships and understanding boundaries. Understanding trauma, again, the high instances of that in this population are important, and making sure that we're being trauma informed, but also providing quality trauma treatment. Then family-centered needs, considerations during pregnancy. So, understanding that that has a lot of impact on a woman hormonally, mentally, emotionally, and she still needs treatment despite, being pregnant. Women's health care, again, big focus on integrated care, and we're seeing a lot of really cool programs around the state really embracing that and growing that. And then collaboration and interdisciplinary effectiveness, making sure that we're all talking and understanding what's going on with this patient to meet her needs holistically. So just talking about how they're addressing these needs in Ohio, we're providing family-centered care by assisting child care needs, trauma-informed care by, seeking safety beyond trauma, the EMDR, allowing children to reside in the programs with women and some of the residential programs has been really important and helps with their success. A woman's going to have a hard time focusing on her own recovery and needs if she is separated from her child or doesn't know what's going on with her kiddo. So allowing the baby and children to reside there with them again helps with attachment, all kinds of great things. So I'm really excited that we have so many agencies doing that in the state. A lot of our agencies partner with Help Me Grow, pediatricians, children's services to make sure that developmental and medical needs are being met. Programs are connected with other community agencies to provide wraparound services. And since they must prioritize pregnant women, a lot of them are connecting with local OBGYN services or having, some folks come on site to help with these needs. So some agency examples just to kind of give you an idea of what, some specific things are going on. In Lancaster, we have the Recovery Center and they have a program called the Pearl House, which provides recovery housing for the entire family with SUD. So it could be mom, partner, kiddos, and they've talked about just some of the really great success stories they've had there. So these, again, family-centered care is just really important. Not leaving out dads. I think we assume sometimes that dads don't want to be involved or shouldn't be involved, or we have to include them too on this. In Dover, we have the River Haven program, another residential program, and they are partnering with their local health department that comes on site to provide things like immunization, STI testing, linkage to primary care, things like that. And then at Conquest in Canton provides trauma-informed care. They also have a domestic violence agency that's like right next door. And so they are able to address the IPV and relationships needs that way. So again, that partnership and collaboration is really important. And then in Cincinnati, First Step Home addresses the unique needs of pregnant and parenting persons by having a pediatric nurse and family case manager on staff to provide education and support right there while the woman is receiving her SUD treatment. So a couple of success stories. This one, we can see we had a mom who was referred to local treatment by Children's Services. A lot of times these referrals do come from Children's Services, but she had a baby that tested positive for some drugs when they were born. Mom completed outpatient treatment successfully, but still struggled with substance use during treatment before achieving abstinence, which I think we all know is pretty typical. But the thing I'd like to highlight about this story is we have a couple programs in Cleveland that will offer their services. They have native Spanish speaking clinicians. And so this woman was able to receive this like culturally sensitive care and really meeting her needs and felt understood and was able, she said, I want to continue to participate in my sessions because it helps me express myself. So she was able to work with Children's Services and get her family and parental rights back, and her case was closed. And so it just shows that, providing these services are meaningful and helpful. We have another success story, which again, I think unfortunately is not an atypical situation where you have a mom who has several children who she's already lost custody of and is pregnant again. And so, you know, this agency worked with her. You know, Children's Services had taken this baby into custody as well, but this agency really worked with her on getting through her treatment. She did residential, partial hospitalization, IOP, and outpatient to really work on herself. She worked with Children's Services and is now sober and living with her daughter in recovery housing. So again, it's not giving up on these women because of their past, seeing, you know, if this is the time she's ready, we can work with her and she can still have success. And so some of our state initiatives that I kind of wanted to highlight today and just let you know what we're doing at the state level. Some of you may have heard there's the Ohio Perinatal Mental Health Task Force. This is something you can join as a professional if you're interested, but they are looking at just amplifying awareness of perinatal mental health. They're starting to include SUD in that, and making sure that we have a good system of service across Ohio. So they've done some legislative advocacy. They've done, you know, I was just on one of our meetings this week. They're connecting people with training as clinicians, just a lot of sharing of information, connecting folks, networking, so that way we're all just working together on this same mission. Ohio Infant Mortality Task Force. I've sat on this for a few years now. Even prior to this role, when I was working in the women's prison, I worked specifically with pregnant women there, and there's a nursery program with babies and moms. So I sat in on this task force there as well, but it is really just looking at our high infant mortality rate specifically for Black babies and how we can work with Black families to improve those numbers and help everyone just, you know, do their best. There is an Ohio Perinatal Quality Collaborative, and they are working on screening and an environmental scan to kind of give us feedback at the state of some gaps and needs. MHA of Ohio, who also does the task force, has a poem. They do a lot of support groups, linkage to women to services. They train perinatal peer supporters. They're doing a lot of really great work. So they have Poem and then Poem Rise. They have one program specific for Black families as well to provide that culturally sensitive services. And then some of us at the state have realized, you know, we have a lot of similar programs going on. So Ohio MOS, DCY is Department of Children and Youth, and then Medicaid. We have collaborated amongst ourselves, and we are doing a mapping right now of all these similar programs and efforts to ensure we're all working together at the state level. I think we get siloed a lot and kind of do our own thing and duplicate efforts sometimes. So we're trying to make sure we're being as efficient and effective as we can at the state level. We have here at Ohio MOS, my colleague oversees this, the Fetal Alcohol Spectrum Disorder Steering Committee. And so they are looking at FASD needs and do a lot of education and advocacy and work with families. And they work closely with DODG and the Department of Health on just a lot of education and just some really, really great work in getting providers in the field trained, families, the support they need for their kiddos. But yeah, doing a lot of great work. The Maternal Opiate Medical Supports the Moms program. So that is a model of care coordination that was developed here in Ohio with a lot of different folks from a lot of different agencies, but it is something that we use some of our federal funding and put into programs around the state to ensure that pregnant women are getting the MAT care they need. And again, that care coordination linkage and making sure they're getting all of their needs met holistically to be successful. So they provide a lot of really cool services to parents in that. And then Department of Children and Youth is also overseeing an AIM SUD bundle, and we're just kind of getting started on some of the recommendations there and working with some OBGYNs and other providers around the state to improve our services in birthing hospitals around the state. And then I have that, so I can open it up for questions or things you want to share.
Yes, do we have any questions from the group?